Now we're going to look at how we can actually use all, in a sense, all Medicare data, including MA encounter data and fee-for-service claims data and Part D data. So briefly, so MA encounter data files contain very similar records to fee-for-service claims data. So their encounter data are conceptually really equivalent to claims data. And currently we have MA encounter inpatient data, outpatient data, and carrier files. It's very similar to actually fee-for-service claims. And we have encountered DME, durable medical equipment, and then special skilled nursing facility and home health agency data. There's one difference is that fee-for-service data, we have a MedPAR, which is already organized at the discharge level, combining both inpatient and skilled nursing facility discharges. However, in encounter data, we have a separate inpatient and skilled nursing facility, and these are not really, particularly the inpatient data, these are not discharge level, so you have to do a little bit work. Now, and then we have Part D data. We can select the Part D data from MAPDs or using PDE, then you can actually examine relation between medical and pharmacy services for MA enrollees. So in this study, I'm going to show how we actually used MA encounter data and fee-for-service claims and Part D data to compare resource use for medical and pharmacy services and quality of care as well, actually, between MA and TM or fee-for-service. So just one comments on using MA encounter data. So ResDAC offers a workshop, separate workshop for that to cover this topic. I think one is scheduled in coming July, I believe. So I encourage you to take that workshop if you are interested in using MA encounter data. But just a couple of issues that you have to consider when you use MA encounter data. So the first, the MBS file, the medical beneficiary summary file includes all medical beneficiaries, right, including MA enrollees. But there are some different segments, and then MBSF, and there's a chronic condition segment, and that file includes only fee-for-service beneficiaries. So there is no already constructed chronic condition segment for MA enrollees, which means that you have to create condition indicators for MA enrollees using MA encounter inpatient or MA encounter records for Part A and B services. Second, there is no cost variables in encounter data, so you can add. So you may have to end up using analyzing utilization of specific services. But if you are really interested in some sort of financial aspect or cost aspect, you can assign standardized prices. For example, like a fee-for-service payment to each service provided in MA sector, and you can examine global measure of resource use, which we did in the case study that I'm going to discuss. And then finally, MA encounter data has some chart review records which are not present in fee-for-service claims. So for your own study, you have to decide whether to use chart review records or not. This is, again, probably depends on your research aims, and also it's your discretion, researcher's discretion, right? So with that, I'm going to introduce one study. So this is comparing resource use and quality of care between MA and fee-for-service. I think this article is not publicly available yet. It's in press, but somebody provided me link, but the link doesn't actually show papers. Later, I'm going to show another link that in a study that, yes, again published very recently, the use of all MA and fee-for-service and Part D data. And I'm not going to discuss that study today. Okay, so for background of this study is that so we have a fair amount of Medicare Advantage and traditional Medicare comparisons, but most of those existing literature are coming from somewhat narrow settings, like a patient with a specific condition, or if you're lucky enough to have access to data from one MA insurance company, so people have looked at MA versus TM for those narrow settings. And also, the current, the existing MA and people service comparison is really from before the Affordable Care Act period. It's somewhat, the earlier years of MA. So we do not have any evidence based on the national data in recent years when MA has grown substantially. So we wanted to provide a little bit more updated reports. And also a lot of studies were focusing on a couple of very specific measures, particularly focusing on more HIDAS type, like use of recommended services, but few studies examine both the financial aspect, cost issues, and then health-related quality outcomes together. So, we want to look at both, because when they save cost, do they harm quality? In order to answer that question, so we want to actually look at these two different aspects together. That was the lack of the study is because of lack of MA data comparable to TM claims until recently. So now finally this MA encounter data came in, so we can actually compare this Medicare Advantage and traditional Medicare or fee-for-service. Yes, I am going to use the term TM a lot, and this is traditional Medicare. I know traditionally ResDAC uses the fee-for-service, but just it's just my preference using traditional Medicare, because we now trying to stay away from fee-for-service a little bit in TM sector. So using like affordable care organizations, etc. So I'm trying to distinguish a little bit, not necessarily there or fee-for-service. So the study objective is to compare resource use and quality of care between MA and TM using nationwide data during a period of MA growth. So, and in addition, we're going to examine the heterogeneity in the MA effects by patient risk. So data sources, we used the data between 2015 and 2019. And essentially, we used almost all data, right? Beginning with the Medicare summary, beneficiary summary files and Medipar for traditional Medicare side, and also Medipar includes some inpatient record for MA enrollees as well. And we have MA encounter inpatient files, and for outpatient files, we have both the MA encounter and TM claims, and carrier files, MA encounter and TM claims, and Part D, and also we have a PDE records for both MA and TM. We also had hospice files. One thing that we are missing here is a post-acute care, skilled nursing facility and home health agencies. We just decided not to use. We found that particularly during this time period, we thought that there are many missing records for this post-acute care files. So our study population was random 20% of traditional Medicare fee-for-service beneficiaries between 2016 and 2019. And for MA sector, so MA encounter data are relatively new. So there was some concerns about that it's a sort of a completeness of MA encounter data. So we first validated the completeness of MA encounter data against using some external data sources. And then we first identified MA contracts that had highly complete encounter data. So we identified 810 contract years out of 1,379 contract years. The validation process is published separately in a separate paper. So you can actually see all the contract IDs that we actually selected for the study. So out of those potentially complete contracts with the complete data, so we selected a random 50% of sample. And then we require the beneficiaries to have a full medical coverage A and B and D given in a given year. Now, so construction of analytic files, so these are pretty much similar. We have looked at this now a couple of times. So first, we apply the sample selection criteria using MBSF coverage restrictions, and we also identify MA and TM enrollment the indicators, and also we keep some demographic information from MBSF. Now the second step is the constructing outcomes. So our first outcome measure is a resource use per beneficiary per month, PBPM. So to calculate this one, so our goal was not really looking at one specific type of service, like inpatient, then you can simply use inpatient utilization or outpatient number of physician visits. Our goal was I wanted to able to combine all these inpatient and outpatient or party or hospice, and I wanted to come up with a total cost. But we don't have cost or payment information in MA data. So we assigned TM payments, the traditional Medicare or fee-for-service payments, to services provided in both MA and TM. So TM side, it's pretty similar what they actually were paid. Not exactly the same, but their payment. The MA side, with no cost information, we simply assign based on HCPCS or DRG code. It depends on service type. So we applied this standardized prices, which is a TM payment, so that we can combine the resource use or cost across the different types of services. So we can have some dollar term, right? So total cost is similar to total actual cost in our TM side. So we did that by service because the way when we apply the prices, standardize the prices, and it really depends on what's the identifier and how do we assign prices depends on the service type, right? So for hospitals, we use the DRG. Outpatient, we use the HCPCS. Professional service also HCPCS. Part D drug, we use the NDC. Hospice, this is a combination between HCPCS and revenue center code. So, and then total resource is, we summed up all the resource use for the categories we listed here. So that was our resource use or outcome measures. This is a dollar term per beneficiary per month. The second, we also had some quality of care measures. There are two categories of quality of care that we measured. The first one is occurrence of adverse health events. So which we believe that they are coming from potentially ineffective or inappropriate outpatient care management. So we had three measures capturing adverse health events, 30-day hospital readmissions, and avoidable ED visits, and preventable hospitalizations. And then, but if we look at only these events, these are all negative right? So these are adverse events, right? But if we see some reduction in these adverse events in MA, we were a little bit concerned that what if that captures simply the restrictive utilization management. So it's not like improving quality of care, but might be just reducing utilization of any hospitalization, etc. So we wanted to come up with some look at some quality measures that might have potentially increased in MA when it's particularly appropriate. So we had three process-based quality of care measures. So the receipt of breast cancer screening and HbA1c testing among patients with diabetes and nephrology care among patients with diabetes. Now, in order to construct these quality measures, we use the inpatient encounter data, Medicare data, outpatient claims, and encounter data, carrier claims, and encounter data. So essentially all A and B data. So, but one thing to note here is that you have to construct the conditions for MA enrollment. So here you see that we selected only a patient with a diabetes. So we don't have a diabetes indicator in MA encounter data. So we follow the CCW algorithm and then we construct the diabetes indicator. So that was our outcome measures. And then another thing that I wanted to introduce here is, so when we compare MA, Medicare Advantage, or traditional Medicare, the sample selection is an issue. In other words, healthier people are likely to sort of enroll in MA. So we want to adjust for health risk between these two types of program. So we measured patient risk, health risk, by hierarchical condition category scores, which CMS uses to adjust MA payments. So, but because of these HCC scores are used for MA payment, people are sort of concerned that there might be some intensive coding in MA, which means that MA plans have incentives to record as many diagnoses as possible, because that is going to increase risk-adjusted payment the MA plans. However, TM providers do not have that incentive. So this has been an issue in the MA sector. So to address this intensive coding in MA, we excluded the diagnosis from health risk assessment and chart reviews from computing HCC scores for MA enrollees. TM data does not have a chart reviews, but TM providers also they have a HRA health risk assessment records. So we also excluded diagnosis in HRS for TM beneficiaries as well. These two HRAs and chart reviews are identified as main sources of intensive coding by MA plans. So when we excluded skip this. When we excluded these diagnoses from these two sources, HRAs and chart reviews, actually that deflated HCC scores for MA enrollees by about 9%, more than 9%. So if we didn't do this deflation, we might actually overestimate MA effect by just saying that it would look like if we didn't have this deflation, it would look like that MA enrollees are much sicker than maybe potentially that actually their actual risk. For analysis, so using this HCC scores, we did a propensity score matching. It's a little bit more complicated. It's not simple propensity score matching. We did a sort of 9 or 16 different ways of weighting and matching at the county level. So we did its condition groups, or we did a lot of some matching process just to ensure that we have a balanced characteristics between MA and TM. And then we used the generalized linear model. Okay, here are some results. This shows some trend. The first graph shows results on total resource use. So if you see here, 2016, this is a reduction in total resource use or total cost in MA. So it was about $230 or $35 in 2016. All the dollars are measured in 2019 dollars, but reduction in MA, the reduction in cost in MA was become a little smaller in 2017 and a bit more smaller in 2018, and then it flat out. So still, we can say that total resource use was lower in MA than in TM, but the gap in resource use between MA and TM shrank somewhat, some moderate decrease in the gap between MA and TM over time. And quality care measures, hospital readmissions, again, MA had a fewer hospital readmissions. MA enrollees had a fewer hospital readmissions, about 3 percentage point difference. And here, but it's pretty similar across all years. And also MA enrollees had fewer preventable hospitalizations, and it's pretty similar across years. For avoidable ED visits, it's interesting. They had actually, MA plans reduced the avoidable ED visits in the earlier years of 2016 and 17, but over time in recent years, we do not see difference between MA and TM in the avoidable ED visits. And then these are the trends in differences in quality of care. Now, process-focused quality of care measures. So we can see this is not just to show that this decrease in this hospitalizations or ED visits is not really driven by restrictive utilization management by MA plans. We looked at some recommended care service use, and here you can see the MA enrollees had higher utilization rates for these recommended services, breast cancer screening or some testing. And over time, we do not see much differences. Now, the next study we did was that this is by patient health risk. So the reason that we did this one is that, so people tend to think that MA plans want to enroll healthier patient in order to save money or to have more profits. That's a conventional wisdom. However, if you think about it, low risk or healthy beneficiaries, they spend little. They don't have a lot of higher level of utilization. So that means that if you enroll sicker patient, then they might have more opportunities to save money, because high risk patient, they use a lot of services, and then when MA plans apply some utilization management, they have a much more chance to save money here. So that's why we did some by health risk subgroup analysis by risk measured by HCC. So high risk means that it's a top quartiles in HCC. And we found huge differences in total resource use between MA and TM by patient risk. So among high risk patient, MA plans save about $500, more than $500. But among low risk patient, MA plans save about probably $70 or $80 per member per month. Okay, and also then, okay, fine. So high risk patient, the MA plan to save more. Oh, why is that? If they because they are cutting out even necessary services as long as they are expensive. So we wanted to look at then what's the impact on quality. In other words, a larger cost sharing among high risk patient, is that coming from at the cost of quality, sacrificing some quality of care. So when we looked at hospital readmissions and all these adverse events, we found that actually even greater reduction in adverse events among higher risk patients. So this is somewhat suggestive that the larger reduction in cost among high-risk patients in MA may not necessarily sacrifice quality of care of those high-risk patients. And when we looked at this recommended service use, we also see that actually even larger increase in use of recommended services among high-risk patients. So this is just a really brief sort of a presentation of the study that we did. We tried to be as comprehensive as possible in comparing MA and TM in this study. So there are a lot more measures that we looked at and a lot more subgroup analysis we did in the paper.